So hello, this is Zane Horowitz and our crew for the Oregon Poison Center Toxicology Journal Club for February 23rd, 2023. And today we're going to be revisiting the topic of psilocybin mushroom uh, exposures and whether or not it works for depression and a variety of other problems. To give you a little bit of background on this, just last few weeks, the entire country of Australia, their Therapeutic Goods Administration, approved both psilocybin and MDMA, ecstasy essentially, for use by psychiatrists to prescribe for certain mental health disorders. And obviously, Oregon was one of the leading states to do this. But there's bills in three or four other states, including Washington, just to the north of us. And there's applications in Canada to approve a variety of products that are over the counter that contain psilocybin, including as I was surfing the internet on a day like today where it just snowed in Oregon. This sounded absolutely delicious. Hot chocolate with psilocybin in it. I mean, how can you get better than that? Um, but to roll the time back about 2 years ago, there was an initiative on the ballot called Oregon Measure 109, and which is called the Psilocybin Mushroom Services Program Initiative. And it asked the voters to either approve or disapprove the creation of a agency authorized by the Oregon Health Authority called the Oregon Psilocybin Advisory Board, which over the next 2 years, which is now at the end of those 2 years, put together the rules by which a facilitator could become licensed or registered to administer psilocybin in essentially a non-medical but observed situation. These facilitators don't necessarily have to have any background whatsoever in medicine or psychology, just be interested parties. And this went to the voters. There was $5.3 million spent on the pro measure advertising. There was $0 spent on the against it advertising. A variety of people came out on the ballot for it, a variety of senators, representatives, people running for office, all the way down to the local municipal level, a variety of unions and other interested parties. And although there was no formal opposition to it, there were statements issued by the American Psychiatric Association, the American Medical Association, the Oregon Medical Association, the Oregon Psychiatric Physicians Association, the American Academy of Child and Adolescent Psychiatry, and the Oregon Child and Adolescent Psychiatry, all recommending this not be approved. So despite that, the final tally was 56% for and 44% against, and it was passed, and the Oregon board was established. And after 2 years, they have come up with some guidelines about how they proceed. I was going to ask Dan Sudekin, one of our faculty who had just published literally today on this process, he had any comments on how that process went, as I know he covered some of this in his publication.
Sure. So it was a transparent process. It took place kind of during the deepest, darkest times of the pandemic. So the iterations that, the board that met and provided recommendations met kind of just like we are right now through Zoom. With all of the choppy communications and all of the baggage that goes along with that. But there were a lot of opportunities for public comment. And I did note in my commentary that the board did not either solicit or receive any input from someone with a toxicology background, whether a clinical or a medical toxicologist. But again, it was a transparent process, and one that took place when a lot of people, I think, were busy with a lot of different things during the pandemic. But the rules are written into law right now, and there's a whole cohort of people who are in the process of training to become facilitators, and there's a handful of facilities that are applying for licensure to become these service centers where people will have to go to ingest and to be observed while they're having their experience. So it's a really interesting sequence of events that's likely to have a lot of different sorts of outcomes that we're all going to see over these next few months.
Yeah.
Hey, Dan, I can add to that. I would say it was more forceful than just not seeking medical toxicologists, because I know of at least two, including myself, that applied to be on that board and was rejected. And that was really in contradiction to the Cannabis Rules Commission, where they actually sort of penciled out who they would ask to make sure that they had a nice balanced group that would have all the information, so that they can make smart decisions. This was I don't know who made that selection, but I know I applied and was rejected from that. So
the only other piece I would just throw in is that, and I do speak to this in the commentary, is that the person who was the chief proponent of making this a ballot measure that ended up getting approved by Oregon voters, it was written into the measure that that person would be on the advisory board, which they were. They were the chair of the board until they resigned or stepped down from the board at some point about a year and a half ago. This was after a lot of the preliminary rules, had been written into effect, and that person resigned after having disclosed that they had some conflicts of interest and that they're developing one of these service centers that's basically going to go live these next few months. So, it's just part of the process, but something that I think people should be aware of.
Yeah. Well, I think with that, I would want to dive into, as toxicologists, as medical people, what do we know about how psilocybin works, and what is published out there about how it may or may not be effective. Obviously, I fear that more states will be jumping on the bandwagon, as essentially Australia did. But the truth is, there's limited scientific information out there. I wanted to start out with an article that delves into a lot of the basic pharmacology, called the Dark Classics. There's a series of articles from a variety of alternative medicines and hallucinogens that are in the Dark Classics, ACS Chemical Neuroscience Journal. But this one specifically devoted to psilocybin. So I'm going to go to Ruby to tell us about that.
Okay, so this is a review in which psilocybin is a tryptamine alkaloid, and its use has been dated back long ago for medicinal and religious purposes by the Mexican Indians. The psilocybin and psilocin, which is its active metabolite, was first identified by Albert Hoffman, and in the clinical studies started to use it in the 1960s and 1970s, and that initially showed an altered state of consciousness, alterations in perception, mood, thought, time, space, and self. As it became more of a popular hallucinogenic recreational drug, then in 1970 it was classified as a Schedule I drug. Structurally, it's very similar to other endogenous neurotransmitters such as serotonin, melatonin, and then this N,N-dimethyltryptamine, which is thought to be the endogenous psychedelic. As for its metabolism, once it's ingested, it undergoes hepatic first-pass metabolism and gets rapidly dephosphorylated into psilocin through this unknown enzyme. Psilocin then undergoes phase 1 and phase 2 metabolism, and its metabolites are renally excreted with a half-life approximately 3 hours. In most developed countries, it's illegal. Psilocybin and mushrooms are legal. The one exception is the Netherlands, in which the loopholes, they have it in truffles. And specifically for psilocin, which is the active metabolite, it acts upon many serotonin receptors, also histamine 1, alpha 2, and alpha 2B, 2A, 2B, and dopamine receptors as well. It also inhibits the SERT transporter, so therefore a higher concentration of serotonin accumulates in the synaptic cleft. And its psychoactive properties are thought to be due to 5-HT2A receptor. Also, there was an argument debate that maybe a component of this is also the 5-HT2C receptor. But they did some studies where patients were given an antagonist to the 5-HT2A receptor in patients who psychedelic users, and found that it had inhibited hallucinations, but the 5-HT2C did not. So as for the 5-HT2A, besides neuronal activation, it also enhances memory and learning, and also smooth muscle relaxation, anti-inflammatory effects as well, produces oxytocin, prolactin, and renin. And whereas dopamine 2 is normally associated with psychiatric illness and hallucinations, it has little effect with psilocybin in this case, because they had given patients Haldol, and these patients did not have an augmented psychoactive effect. So it's thought more so on the dopamine receptor, which psilocin has a high binding capacity for it, but it's unclear as for its mechanisms. Then there's also psilocybin, saying that right?
Mm-hmm.
Which is a chemically modified precursor to psilocin, and it's found to have a faster onset and without the causing anxiety or nausea that's commonly associated with mushroom ingestion. As for its therapeutic window, it's pretty wide. Like in animal studies for behavioral changes, they use less than 10 mg per kg, which some of it was even less than 1 mg per kg, but the LD50 in rats was closer to 300 mg per kg. So a lot of this was also limited to the nausea and vomiting that's associated with the mushrooms as well. For clinical effects, it's pretty dose dependent, but patients will get a physiologic, visual, auditory, cognitive, transpersonal, and multisensory effects such as synesthesia, which is color association with numbers or letters that you can see. And in higher doses, it seems to be more stimulating with really a lot of visual effects, whereas low doses is more sedating and some enhanced visual changes. Patients also describe this physical euphoria, this body high, where they get a light, pleasurable sensation covering their body and glowing weightlessness. So basically, it's a warm hug that you get. But full
Perfect with
duration
hot chocolate, right?
through hot chocolate. The full duration is 4 to 7 hours, but it can last up to 24 hours for the after effects. And for more severe effects, patients can get this hallucinogen, persisting perception disorder, seizures, and this hypothetical risk of cardiac valvulopathy, really from the HT2B receptor. Then there are drug-to-drug interactions. The most dangerous is tramadol, which both medications synergetically is more seizure prone. And then cannabis taken with psilocybin can either cause this paradoxical reaction where they get intense anxiety instead of relaxation. Then there's amphetamines, which is, interestingly, patients are at risk of developing this thought loop, which is this repetitive set of thoughts or ideas. And then briefly it goes over mushroom foraging, people who forage mushrooms. The deaths have occurred from people who are looking for Amanita muscaria and then instead get phalloides or misidentification that is truly Amanita phalloides instead. The most interesting part of this review, in my opinion, was studies on terminal cancer. Fascinating. So the studies looked at depression and anxiety in patients who had either late stage cancer, and there were 2 studies that looked at this specifically, and they found that there was a reduction in anxiety and depression, and overall an improvement in the quality of life even after a single dose. Another study of cancer patients showed that there was a large decrease in clinical and subjective measure of depression and anxiety. And then on a 6-month follow-up, they had an 80% significant decrease as well. These patients had better improvement in attitudes towards death and experience. Sorry, excuse me.
Mm.
Likewise for tobacco, these patients had an improvement as well regarding like their addiction with tobacco, and also had an improvement after 36 weeks as well. So drawbacks, and one study with 44 patients, they found that dysphoria was the most common reason for patients to be admitted to the hospital. They had changes in behavior, aggression, and violence. And for patients who were like using it for non-research purposes, these patients were at risk of physical harm and also experiencing basically a bad trip in which they were having psychological problems or negative effects from it. So overall, that's the review.
Yeah. So you're right. So there's a downside. Obviously, I'm not sure how well they are going to select the patients who come for these therapies, or whether they just show up and say, "I'd like this therapy," and they do the therapy. I'm not sure how the rules are going to pan out, but in a huge survey of like 2,000 users, a big percentage of them had relatively negative experiences from this, including fear, anxiety, dysphoria, paranoia, things like that. So it's not entirely safe, but the risk of acute death seems to be pretty low with it. Just want to do one more paper on the pharmacokinetics of it, which comes from a drug metabolism review. So I'm going to do that before we dive into the studies, looking at how well it stands up for its proposed uses here. So Joe, tell us about its metabolism and kinetics.
All right, let me share my screen with you guys. So here is figure 2 from this article. I just want to keep this up on the screen while I go over everything. So my paper was called The Metabolism of Psilocybin and Psilocin, Clinical and Forensic Toxicology Relevance. And the clinical questions they're asking was, what is the metabolism of psilocybin and psilocin, and what are the clinical and forensic toxicologic implications of this information? So this was a study where they reviewed available literature on the metabolism of psilocybin and psilocin. Basically, the primary outcome was to review available literature on the metabolism of psilocybin and psilocin and to discuss the clinical and forensic toxicological relevance of this information. So they talk about, the first part of this paper talks about absorption, distribution, and excretion. They mention that psilocybin is typically administered orally. It can be in the form of a drink or a chocolate bar due to its unpleasant taste. They also mention that it can be smoked. The article notes that psilocybin is more soluble in water than psilocin, which has a highly polar phosphate group, and as a result, psilocin is more easily absorbed from like a rat jejunum and colon, indicating a greater central nervous system bioavailability. The pharmacokinetic studies in animals have shown that only 50% of carbon-14 labeled psilocybin is absorbed following oral administration, and is almost uniformly distributed throughout the body, including the brain, where it exerts its psychedelic properties. Psilocybin is rapidly hydrolyzed in the intestines to psilocin. In vivo studies in rats show, indicating that psilocybin is absorbed mostly or even all as psilocin. In humans, psilocin is detectable in significant amounts in the plasma within 20 to 40 minutes after oral administration, and the maximum concentrations are reached approximately 80 to 100 minutes. The effect of psilocybin in psilocin is completely disappears within about 4 to 6 hours. The article also notes that psilocybin and psilocin have an elimination half-life in plasma of about 160 to 50 minutes, respectively. In vivo studies show that rats have shown that psilocin is excreted in the urine about 65%, and bile and feces are 15 to 20% within 8 hours after oral administration, with about 10 to 20% remaining in the organism for a longer amount of time. The metabolism of psilocin has been detected in the urine 7 days after oral administration. Approximately 25% of the whole dose was shown to be excreted unaltered, and a controlled study in humans showed that within 24 hours, 3.4 plus minus 0.9% of the applied dose of psilocybin was excreted in the urine as free psilocin. Later pharmacokinetic and forensic studies reveal that psilocin is approximately 80% eliminated as psilocin O-glucuronide, and the enzymatic hydrolysis of this conjugate during analysis extends the time of detectability for psilocin in the urine samples. So in regards to the metabolism, I think Ruby hit on some of this too. Psilocin is a prodrug, which means that it is converted to its active form, psilocin, in the body. After oral administration, psilocybin is rapidly dephosphorylated under an acidic environment in the stomach or by alkaline phosphatase in the intestines, kidney, and possibly the blood to generate psilocin, which easily crosses the blood-brain barrier. Psilocin is a responsible compound for the psychoactive effect of psilocybin. Psilocin undergoes comparable human metabolisms to the neurotransmitter serotonin, and it is further metabolized by demethylation and oxidative deamination, catalyzed by liver MAO or aldehyde dehydrogenase to yield 4-hydroxyindole-3-acetic acid, 4-hydroxyindole-3-acetaldehyde, and 4-hydroxytryptophan. I think I pronounced this correctly. MAO inhibitors are also consumed by psilocin abusers to intensify its hallucinogenic effect. Ethanol may also enhance the trip since its primary metabolite, acetaldehyde, reacts in vivo with endogenous biogenic amines, producing MAOI inhibitors, tetrahydroisoquinolinines, I think, and B-carbolines. Tobacco use is associated with lower levels of MAO in the brain and peripheral tissues, and therefore extending the effects of magic mushrooms synthetically. Psilocin may cause competitive inhibition of MAO, and this enzyme also metabolizes serotonin, so brain levels of serotonin may be elevated and simultaneously 5-HIAA may decrease. Psilocin may also be subject to extensive glucuronidation by UDP glucuronoltransferase, UGT1A10 in the small intestines, and UGT1A9 is likely the main contributor to its glucuronidation once it has been absorbed in the circulation. The analysis of psilocybin and psilocin in the body fluids is challenging since its analytes are rapidly metabolized and unstable under the influence of light and air, especially when in a solution. Blood samples stored at room temperatures evidence a continuous decrease of about 90% of psilocin and psilocybin concentrations after 48 hours. Therefore, it's essential to collect and store the samples appropriately to avoid false negative tests. So, kind of to sum this all up, the authors found that psilocybin is rapidly metabolized in psilocin, which is the active compound responsible for the psychoactive effects of psilocybin. Psilocin is further metabolized in the liver and excreted in the urine. The authors discussed that the clinical and forensic toxicology implications of this information, including the interpretations of drug test results, detection of psilocybin in post-mortem specimens, and the potential for drug interactions. I thought this was a very interesting paper, especially for the implications of further decriminalization and legalization of magic mushrooms in the future in Oregon and in various states. So, yeah, interesting stuff.
Yeah, no, it's good basic pharmacokinetics. I think one of the important things is if we're going to do some sort of forensic testing, we need to measure not just psilocybin but the active compound that it's converted to, psilocin, and it says that we have to handle these specimens appropriately by freezing them because there is some degradation that goes on if it's not frozen. But I'm not sure how set up like labs and coroner's offices, medical examiners will be. Look for this in like post-mortem or criminal cases. But Rob, if you have a comment on this.
Yeah, I was curious, Joe, given the info you just presented, what would you predict might be a interaction? I always think about what if someone had renal failure, because we just had similar experience like that recently. And what if someone had, genetic variability in their metabolism, and then so what would you predict? And then I don't know if there's actually any evidence for any of these things.
I guess liver failure would be a big thing, but also renal failure too if it's excreted in the urine too. So any of those would probably change how it's metabolized in the body, and how long it lasts and stays in, and the effects that it has.
Yeah, so correct me if I'm wrong. I think that glucuronidation is fairly well preserved until you're pretty severely incapacitated with liver failure, because the patients with liver failure still glucuronidate their bilirubin. They still have conjugated bilirubin. So I don't know which ones, but I don't know. Yeah, I suppose really severe liver failure. And then I think it's all glucuronidated, right? And then urine excretion. So if you have a normal liver, then would renal failure or
well, it said that some of it was excreted unchanged. I think there was like 20 to 25% excreted unchanged in the urine. So if you're not able to urinate it out, I'm sure you'd have some floating around a little longer periods of time.
And I guess the other one was the sort of ALDH and monoamine oxidase. I always think about very few people are taking disulfiram anymore, but you never know. If you were trying to get high and stay high longer, you might take some. Hint, hint, for good drug taking. And then I guess the other thing is not too many people are taking monoamine oxidase inhibitors, but lots of people take St. John's wort, and that inhibits monoamine oxidase. So would that predict a prolonged psilocin high? I don't know. I don't know if there's any cases, but certainly would be something to think about.
I'll add in reference to something that Ruby said too, is one of the big pushes for this was it helps the people who are, depressed because they have terminal cancer, and there are loads and loads of cancer chemotherapy agents that work and are metabolized through similar pathways. So I'm not sure how well trained these facilitators are to even understand that, because I myself would have to look up if someone was on some potent chemotherapy agent that has a liver metabolism pathway to see if there would be interaction with this psilocybin.
Yeah, these are really interesting, on-point issues. I actually, when I look at the clinical literature, some of the more interesting stuff is, in terms of efficacy, is the end-of-life use of psilocybin, where people probably do have some substantial impairment of, possibly pharmacokinetics or protein binding, and there doesn't really seem to be a higher incidence of adverse reactions. In fact, I think that's really where there's some very compelling, interesting data on its efficacy under very carefully supervised conditions. But one thing I did want to say with regards to the MAO issue is, and this is a topic that I find totally interesting, but didn't make it into the manuscript that I just published. But in the last couple of years, there have been some very interesting natural product studies of psilocybin that have demonstrated very clearly that among the different, in addition to the psilocybin, psilocin is the active ingredients. The cubensis species actually produces this group of chemicals called the beta-carbolines, which are MAO inhibitors, potent MAO inhibitors, and they're actually part of the active ingredients in ayahuasca. So that's super interesting, because in Oregon, one of the decisions that they made was that they, in contrast to the other studies we're going to talk about today, where they actually used a synthetic form of psilocybin, here in Oregon, the rules require that the psilocybin that people are going to be taking are naturally cultivated. It comes from either whole mushrooms or homogenized mushrooms or mycelium, which can contain these beta-carbolines that no one is going to be requiring testing for at the state level. And the whole long and short of it is, when you're looking at natural products like this, that can contain, varying concentrations of these beta-carbolines, a standard 10 milligram dose of psilocybin may be significantly potentiated by some of these MAO inhibitors that are already inherent in that formulation. So I think that's a big issue that has not been touched by anybody, to my knowledge, and something to get out in front of as far as recognizing the potential for adverse effects or unexpectedly strong doses.
Yeah, I mean, obviously, if the FDA treated this like another drug, all these type of studies would be asked for and need to be performed. But we voted this in without sort of oversight from any sort of medicinal agency. Now, that being said, the agency that approved this in Australia, the TGA, is similar to our FDA. So, but they probably had the exact same studies that we have to look at its efficacy, which I was going to move to next, because there are a few, and they are quoted often in every review that's ever been written on this, but there's a few well-designed studies. Let's see if we can pick those apart. I'm going to start, I think I took this slightly out of order I'm going to start with the New England Journal single-dose psilocybin, because I just wanted to look at just its treatment without comparing. I think that's Jeff's article. Is that correct?
Yeah, that's me.
Just wanted to make a comment on that earlier. So by using the naturally occurring psilocybin from plants, you're basically taking that standardizing out of the standard out of standardizing.
Yes.
Yeah, that I think I think that's a big deal, because the studies we're going to talk about right now, when they talk about a given dose of 10 or 15 or 25 milligrams of psilocybin, those are chemically synthesized. You know what you're getting, and we don't have the same capacity here in the Oregon rules to say that in terms of what else might be in the formulation that might potentiate that. So I think it's a pretty big deal.
Mm-hmm. All right. Any other comments on its metabolism and drug-drug interactions? Because I wanted to start off with that. I wanted us to understand how it works and what the body does to it before we jump into some of these studies. All right, Jeff, take it away.
Okay, I'll share my PDF of the article here. So, like you said, this is a New England Journal article. This was just published in 2022 in November. Single-dose psilocybin for treatment-resistant episode of major depression. This was a study, first off, that was funded by a company called Compass, who, as we were mentioning, has created a proprietary synthetically derived formulation of psilocybin. This was a phase 2 clinical trial, double-blinded, where patients were given doses of 25 milligrams, 10 milligrams, or 1 milligram of psilocybin, with a primary endpoint being a change in their baseline score of the MADRS depression score. The primary endpoint covered the sites they used. It was pretty widespread. There was 22 sites in 10 different countries that they were pulling data from. They did... Sorry, did I interrupt someone? They did use, or they did exclude patients who were at risk for suicide, and only used patients who were being outpatiently treated for their depression. So there were no inpatients in this group. They did not define how patients were excluded as at risk for suicide. The structure was similar, I believe, to what is planned for the Oregon psilocybin therapy sessions, in that patients met with a therapist before they began the dose of psilocybin. They established a relationship over a couple of visits. They were given a dose of psilocybin and then had some, headphones placed over their ears with like a curated music playlist, an eye shade placed so that they would kind of direct their attention inward. Went through their session and then proceeded to fill out this MADRS depression score the following day and then a few weeks out from their treatment. Scroll down here to the data. They had a total of 216 people who were randomized, who were followed through to the end for analysis. 233 initially underwent randomization. They had pretty even groups, 79, 75, and 79, who received the 25 milligram, 10 milligram, and 1 milligram doses of psilocybin. And they didn't really lose a lot of people to follow up. 79, 75, and 79 in those groups went into the analysis. Here is some of the demographics, but scrolling down a little bit more to kind of the meat of the data, I'll show you this chart first. These are the change in the MADRS depression scores following their psilocybin dosage. You can see on the x-axis you have their baseline score being at 0, and then day 2 all the way out until week 12, which was as far as the study tracked these folks. And then the differing dosages represented in the blue, green, and gray lines. And then you can see the error bars at each of these follow-up dates. The psilocybin dosage of 25 milligrams brought people all the way down to a change in their score at their day 2 visit of 15 points. And then folks remained statistically significantly separated from those 10 milligram and 1 milligram dosages pretty much all the way out until the 12-week follow-up. It's a little bit muddier with the 10 milligram and 1 milligram dosages. They did see a decrease in their depression scores, but then there's some overlap in terms of statistical significance as we pull all the way out into 3 weeks, 6 weeks, and so on. Coming back up here, we can see some more of that, more of the raw data. The only comparison in terms of between the 25 milligram dosage and the 10 or the 1 milligram dosage, only the 25 milligram dosage showed a p-value of less than 0.001, separating it from those two dosages. I'll pull us down to one more graph. Sorry, actually, it is right here. There were some secondary endpoints that they looked at as well. Response at 3 weeks, which they described as response being a decrease in 50% from their initial MADRS score. And you can see that in the percentages, 37, 19, and 18% of patients had a 50% decrease in their respective dosages. But probably the most valuable piece of data that we would want to know from the study was there was sustained response out to 12 weeks. And 20% of patients saw that sustained response out at 12 weeks in the 25 milligram group, whereas only 5% and 10% in the 1 milligram and 10 milligram groups. I think this study is a bit limited just because of the proprietary nature of the Compass formulation of psilocybin, and it has some bias given that this is a for-profit group who's hoping to go to market with their formulation at some point. And they were the primary funders of the study, and it's also unfortunate that maybe the folks who are at most at risk of being damaged or hurt by their depression, the folks who would be at risk for suicide, weren't included in this study, as well as people who are inpatient hospitalized for their depression. But overall, I think they showed some interesting data in terms of supporting the large dose of psilocybin as giving some benefit for folks in the long term, if we can go 12 weeks long term. And I would have been curious to see them follow a little bit further to see if that change could have been sustained.
And one of the last articles we'll review looks at a longer term outcome, but you're right that for a short term one dose, there seemed to be some change in the score, which is widely accepted as a reasonable score. I do want to point out one thing in the method section that they do say, and something you brought up, was that this Compass group, that the statistical analysis was contracted to a research organization, then reviewed by that sponsor before it was released for post hoc statistical analysis that was performed by the sponsor. And then not only that, the sponsor paid for professional writing assistance. So although all of the doctors and clinicians were on the author list, this was a very controlled who got in and how the statistics were managed, analyzed, and actually how the verbiage of the final product publication came out. But given a one dose, see what it does trial, and I think they were trying to prove that the 1 milligram dose was a controlled subphysiologic dose so they can compare it to the 25 without having a true placebo, because you can never have a placebo because people know if they get psilocybin or not. So there was some effect in a small study.
Zane,
Mm-hmm.
yeah, I agree. I mean, the effect is pretty impressive, but I think what you just said has to be underlined.
Mm-hmm.
Is it kind of all depends on how you rolled out this study, right? If you told people that we strongly believe that psilocybin is going to make your depression better, and sort of presented people repeatedly with that information, the control group very well knew that they didn't get a large dose of psilocybin, because any one of us who got a milligram of psilocybin would not start having synesthesia. I mean, it's one of those things that it's very clear to the person. So if you've convinced the subject that they will feel better, we're not talking about measures of hypertension where there's a objective measure. We're talking about depression score. So this is exciting, but I think we really have to keep in mind that if you tell people that it's going to work, and then you give a drug that does the effect that they say is going to work, and then you ask them, did it work? It's not easy to measure that very well.
I'll also point out that at 12 weeks, the sustained response, being the people who still had a decent MADRS score, was only 20%, and the confidence interval for that actually crossed 1, so it was not statistically significant. So there was a big drop acutely in depressive symptoms, but it wasn't something that continued. One might ask, well, what happens when you take a regular antidepressant? Because we know there are lots and lots of them on the market of a variety of different categories: SSRIs, SNRIs, cyclic antidepressants, even MAOIs. All these different groups are out there, even beyond an NDRI as well. What if we actually had a trial where we compare this head-to-head with something we know is the first-line therapy? So I'm going to bring up the next article that actually looks at that question. So, Marhane, tell us about the head-to-head trial with escitalopram.
All right, okay. Some background. As mentioned earlier, psilocybin is a phosphorylated ester form. Its metabolite is the psilocin, and thought to have its antidepressant effects through agonism of the 5-hydroxytryptamine type 2A receptor, which is implicated in depression. So this study here looked at psilocybin's antidepressant capacity in comparison to an established SSRI, escitalopram. Was a phase 2 double-blind randomized trial involving patients with long-standing moderate to severe major depressive disorder. And this was over the course of 6 weeks, involved patients with ages ranging from 18 to 80. Mean average age was 41. There was 30 people in the psilocybin group, 29 people in the escitalopram, and the patients were assigned to either the experimental or the control group. experimental received 2 doses of 25 milligrams of psilocybin 3 weeks apart, and then had a daily placebo. And the control had 1 milligram of psilocybin given to them 3 weeks apart, and had daily placebos in between as well. The primary outcome was assessment of the change in baseline of their 16-item quick inventory of depression symptomatology self-report at 6 weeks. And secondary outcomes were assessment of response to treatment, which was defined as a reduction of the score by 50%, and remission, which was defined as a score of equal to or less than 5 at 6 weeks. The QIDS SR16, which is the Quick Inventory of Depression Symptomatology Self-Report, asked questions about sleep, insomnia, mood, appetite changes, weight changes, concentration, things that to sum up their depression. Their main exclusion criteria was immediate family history or personal history of psychosis, serious history of suicide attempt, positive pregnancy test, contraindications to SSRIs or undergoing MRI, and previous uses of escitalopram. Although previous use of psilocybin was allowed, and also exclusion of pre-existing psychiatric conditions such as borderline personality that could jeopardize the rapport between the patients and their caregivers. So the results ultimately, the QID or the kids SR16 scores were the mean score was 14.5 in the psilocybin group, in comparison to the score of the escitalopram group, which was 16.4. Mean changes being 8 points or negative 8 points in the psilocybin group, and 6 points, both plus minus 1 for the psilocybin group or the escitalopram group. So there was a change, there was a mean change, and minus 8 in the score for the psilocybin group, and minus 6 in the escitalopram group. So minus 8 and minus 6. The difference between the groups was 2 points. And the scores that they had ranged from 0 to 27. And in response to the secondary changes, like response in general, there was a 70% response in the experimental group, 48% response in the control group, for a difference of 22. In respects to remission, there was a 50% remission response in the experimental group, 28% in the control group, for a difference of 28. Incidences of adverse effects were similar in the two groups, 87% in the experimental, 83% in the control group. And these adverse events included things such as headaches, nausea, vomiting, fatigue, anxiety, dry mouth, migraines, sleep disorders, diarrhea. The confidence interval was 95%, had a negative 5 to 0.09. The p-value was 0.17, indicating that although we saw a response, a difference between the two groups, it wasn't statistically significant between the two groups. A further study is required, bigger numbers, more standardizing of the inclusion and exclusion criteria. Should be noted, 5 out of 29 patients did not complete the protocol for the escitalopram group. 4 stopped taking their escitalopram capsules because of adverse events. One of them missed the dose because of COVID, and one patient stopped taking their one patient had their escitalopram reduced from 20 to 10 milligrams. due to adverse events. And 3 out of the 30 in the psilocybin group did not complete their procedural dosing as well. 2 missed it because of COVID. So overall, there's a response. There's a difference between the 2 groups, just if we're looking at the results. But from a statistical standpoint, there wasn't any statistically significant difference between the 2 groups.
Yeah, and I think that's maybe the take-home point is that in a short trial with a small number of people, there was no statistical difference between established therapy, escitalopram, and psilocybin therapy, even though the number drop on the depression score was 2 points different. Whether that 2 points makes a clinical difference, it's impossible. Probably doesn't. But they had a bunch of secondary outcomes of at least 5 different other scores at 6 weeks. None of those really were statistically significant either. I'll also mention that in order to get these 60 patients, they screened 1,000 patients, 100 of which went past the screening stage to see if they qualified, and at the end of the day, they ended up with 60, of which about 3 to 5 dropped out of each category for one reason or another. So a huge undertaking just to find a selective group in which to find no clinical statistical difference between this and a well-established therapy. Any other?
Which I guess it's not the worst thing, because they didn't at the very least have a statistically relevant difference in the opposite direction.
Right. I don't think it was a harm, so I agree with that. In a way, you could say this is almost, but not quite, a non-inferiority trial. Like if you compare a new drug to an established drug, which is kind of what they're doing. Is it as good as the old drug? And the answer is, statistically speaking, likely so. But the thing is, there's a lot of old drugs that also have treatment failures, so, as this one did as well.
It's not really measured here, but I consider it to be a factor that one of these is a drug that's given, one time over the course of weeks to months, whereas one is something that has to be taken, I assume escitalopram is daily or twice daily,
right?
Which, just for convenience sake, is a big difference.
Right. I agree. So what about comparing this? I thought this was going to be a study which is actually a head-on, 2-arm study, but this actually was a systematic review between 2, psilocybin and another newer agent as well. But I thought it was important to kind of bring it up as what are the other possibilities for treating depression and how well do they work? So Catherine, tell us about S-ketamine and psilocybin.
Yeah, absolutely. So as Dr. Horowitz mentioned, this was a systematic review. It was published in the International Journal of Molecular Sciences in 2022. And the aim of the study was to compare and review the potential use of psilocybin and S-ketamine in depression treatment. So this group searched PubMed and Medline databases for the terms depression and psilocybin or S-ketamine, and ultimately got 617 articles. They were able to wean that down to 12 studies by only including 10 years worth of study, the most recent 10 years, and then they only included clinical trials and excluded poor study designs and things like that. Of these 12 studies, 3 of them were for psilocybin and 9 were for S-ketamine. The subjects of these were all people with depression, and most of them had treatment-resistant depression, but 3 of the studies, it was just depression. And treatment-resistant depression was most commonly defined by having tried 2 antidepressants unsuccessfully. Suicidal ideation was inconsistent. It was an inclusion criteria for a few of the studies, but it was actually an exclusion criteria in a handful as well. So that was a little bit inconsistent, and they ended up having 1,843 subjects included, combined. One note is that S-ketamine studies all compared this drug to the standard of care antidepressants, whereas the psilocybin studies were a little bit mixed. One of them compared it against an antidepressant. Actually, that was the one Barhani just reviewed for us, the escitalopram study. And then the other two compared it against a placebo. So sort of bird's eye view, they looked at 4 different endpoints for these substances. They looked at the rapid effects, the long-term effects, suicidality, and then adverse events. And they got kind of busy with the tables, but I'm just going to kind of summarize a little bit. So for the rapid effects, they first looked at esketamine. And the way that they determined this was they had patients come in who were already on an antidepressant, and they had them have 1 nasal spray of esketamine. And then they assessed them at 2 to 4 hour mark, and then they assessed them again at the 24-hour mark. And similarly to the other studies, so all these studies used the MADRS, the MADRS score that Jeffrey talked about, and they found a rapid decrease in depressive symptoms at both the 2 to 4 hour mark and the 24-hour mark for esketamine intake. There's a significant difference for the 84 milligram esketamine, and then only one of these studies found it for the 56 milligram dose, found a significant drop for that dose. For psilocybin, the design for this one was that one group got a placebo and the other one got the active drug, which we have talked about being not a particularly helpful thing. One way they tried to get around that was by giving people niacin, because it would make them feel something kind of uncomfortable. But they sort of admit that this is a limitation people kind of know if they didn't get psilocybin. So one group would get placebo, one group would get psilocybin, and then they would answer a depression scale. In this case, they used the slightly redundantly named Hospital Anxiety and Depression Scale for Depression, or the HADS-D, and also Beck's Depression Inventory. And of these, only 1 out of 3, so then they would switch them. So the following day, the group that got the placebo would get the active drug, and the group that got the active drug would get the placebo. So out of these, only 1 of these 3 studies reported rapid effects with a significant reduction in the baseline scale. So that's rapid effects. Long-term effects for esketamine, the design for this was patients were given twice weekly esketamine doses, and these patients were on antidepressants, and that was compared against antidepressants alone. There were a lot of different antidepressants mixed into all these different studies. Some were SSRIs, SNRIs, one was mirtazapine, so it wasn't super consistent with the mechanism. And then at 25 and 28 days, these patients were assessed using the same MADRS scale. They found a downward trend in all the studies, with statistical significance being achieved only in 2 of these. And this is table 3 if anyone's following along. And then for psilocybin, this is table 5. This was given during 2 sessions, 3 to 7 weeks apart. And then, as I mentioned before, 2 of the studies compared it to nothing at all, and then the other one compared it to escitalopram. In the 2 placebo studies, there was a significant difference from baseline at 5 to 6 weeks and at 26 weeks. In the escitalopram study that we discussed, there wasn't, but the authors of this paper sort of argued this is maybe a non-inferiority study, as we already discussed. For suicidality, the third sort of endpoint, for esketamine rather, suicidal ideation was an exclusion criteria in 6 of the studies, and inclusion criteria in 3 of them. And this endpoint was a little bit murkier for me. In the studies where suicidal ideation was an inclusion criteria, esketamine was reported to demonstrate significant rapid improvement in depression using the MADRS scale at 4 hours and 24 hours. But this reached significance in only 1 of these studies. But then they also noted that suicidal ideation and suicide attempts showed up in other people who had not had suicidal ideation previously. And these were even reported as serious adverse events in some of these studies, and people were removed from the study because of it. For psilocybin, they only looked at suicidality in 1 of the studies, and that was the study that Barhani just took a look at, and they found that the 6-week, the depression score at 6 weeks had dropped 2 points with the placebo and 0.8 from baseline. They didn't mention significance, but we just talked about that. And then finally, adverse events for esketamine. They, the authors said mild to moderate, but then they went on to report some pretty sort of striking adverse events. So they said, most people just had some mild psychiatric complaints, transient anxiety, disassociation, and then their physical things were mostly sort of headaches, dizziness, nausea, and most resolved the same day. But then all studies revealed some serious adverse events that occurred, including suicide attempts, ANS imbalances, lacunar strokes, simple partial seizures, and fractures. I don't know how somebody gets a fracture from taking esketamine in a supervised environment, but these were reported as serious adverse events. For psilocybin, they were pretty underwhelmed. There were really no serious adverse events. Everything was transient and tolerable, and all had resolved fully by the end of the sessions, primarily sort of anxiety, headaches, nausea, vomiting. Nobody needed any sort of pharm interventions like benzos or anything like that. So limitations, of course, they were using different scales between the studies, and systematic reviews always sort of have that limitation that they're sort of using different rules. There weren't as many psilocybin studies, and then the people in the psilocybin studies, there were smaller numbers as compared to the esketamine. And then, of course, the placebo for the psilocybin studies was quite challenging. As I think Dr. Hendrickson was mentioning, you can't, if people are told ahead of time you're gonna get a medicine that's going to improve your depression, and then they do or do not get that, their subjective depression scale is likely going to change. So sort of in summary, the authors found that the esketamine resulted in rapid improvement in depression, plus or minus suicidality, which can last up to 7 weeks, superior to the standard of care antidepressants. But there were some serious adverse events. Psilocybin had rapid and long-term antidepressant effects, nothing really with suicidality, but both are likely safe when used in a supervised clinical environment.
Right, and I think that last line is probably the key thing, is when you use this in an appropriate clinical environment supervised by these study personnel or psychiatrists, as I think is being proposed in Australia perhaps, maybe it's a second, third choice for therapy for treatment-resistant depression. But again, the numbers, even when they dug through everything ever published in PubMed, they really only came up with 3 studies, which we talked about a couple of them. This is really just done 2022, the end of 2022. So it's not like there's a couple more working out there that we haven't heard of. Mind you, all these studies that we just talked about, and including the next one, all were published after the vote in Oregon in 2020. So there was practically zero in the actual medical literature. Not that these 5 different medical authorities all weighed in, and so no vote recommendation were actually paid attention to, at least on a population-based scale. But esketamine is being used slowly as another alternative, as another agent that also carries with it some risk of misuse. I think maybe the good news is neither of these sort of generated sort of a out-of-study misuse potential, which is always a big concern. People go out and just buy this on the street or somehow misuse these drugs or have diversion of these drugs, which is always a possibility. I was going to follow up with the last study, which is the most recent one, which basically is a 12-month follow-up of one of the earlier studies. So, Matthew, tell us about that one.
Yeah. I'll go ahead and share the PDF I have of the. Okay, I think you guys can see my screen here.
Mm-hmm.
Okay, and I have my notes on the side. So, yeah, this comes out of Johns Hopkins. So this is a prospective study at 12 months looking at the efficacy of psilocybin-assisted treatment for major depressive disorder. So this is kind of just coming from the abstract here. The primary aim is examine the efficacy through 12 months for moderate to severe major depressive disorder receiving psilocybin. It's a randomized waiting list controlled study. So this is like, I had to look this up. So it's a study in which there's a quote unquote control group who essentially just don't receive the experimental treatment right away, but they're put on a waiting list. And so sometimes these waiting lists are indefinite, and so it's a way of getting around the kind of what's the word I'm looking for? Like not giving someone the gold standard of treatment in order to like withholding treatment from them. So it's kind of a way of getting around that and still initiating your study. But then they received the intervention after 8 weeks. So they did eventually get the intervention, just they had to wait a little bit longer. Some of the downsides to this is that there's not really a sham group or really a control group, because both are getting the experimental treatment at some point in the study. So it's not really great for comparison's sake. But there were a total of 27 patients. They were aged 21 to 75. They had moderate to severe unipolar depression based off of this study using the GRID Hamilton Depression Rating Scale, or GRID HAMD, as I'll probably say for the rest of it for the sake of brevity. But this is a scaling system that was kind of modified, I think in 2017 or not too long ago, was like kind of when the newer scale was released. And it has this GRID system that basically allows for better repeatability, better reliability. And so a score of greater than or equal to 17 based off of blinded clinician assessments was kind of what they determined as moderate to severe unipolar depression. So I mentioned the randomized control group. They excluded individuals. I'll scroll down here to where I'm reading. They excluded individuals that had a family history of first or second degree relatives with bipolar 1 or 2 disorders. So this had to be monopolar or unipolar depression without a history of any bipolar disorders in the family. Additionally, patients were required to refrain from using any psychedelic substances for 5 half-lives prior to the initiation of the trial, as well as a month following the second administration. So participants would receive either 20 milligrams per 70 kilogram body weight at the first at the initial treatment, and then 2 weeks later they would receive a second treatment under supervision of 30 milligrams per 70 kilogram body weight. This was administered in a comfortable room under supervision by a facilitator, and then afterwards they would receive non-directive psychotherapeutic treatment on session days at 1 day following and 1 week following each drug administration session. Then they would come back and be followed up at 1, 3, 6, and 12 months following the second session. So I don't know how that happened necessarily for the delayed group. I guess they didn't get the 12-month follow-up. They got a 12-month follow-up, but it wasn't after the 12 months after their second administration. All participants received an fMRI at baseline and then 1 week after the second psilocybin session. Some of the outcomes that they were measuring, the primary outcome is just depression severity. And this was also, again, using the GRID HAMD scale, assessed by blinded clinician raters via telephone, as well as some self-reporting questionnaires that they also included. Participants also rated their measures of the psilocybin effects that they experienced. So this is measured on the Mystical Experience Questionnaire, which is a 30-question questionnaire called MEQ30. It's all like single-item measures on which they rate the degree that each session was personally meaningful to them, spiritually significant, psychologically insightful, or psychologically challenging, and they're like on a scale of 1 to 8. And then there was overall well-being attributed to the psilocybin treatment sessions. This was just self-questionnaires, and then they measured adverse events and recorded safety measures, because this was kind of an efficacy trial as well, seeing if there was adverse events that were meaningful. Skipped some of the statistical analysis portion here. So kind of the primary results. This is included here. This is kind of their control or their study group. Primarily 67% female, and 92% Caucasian. There was one participant identified as Black, another as Asian. So pretty limited generalizability here as far as the cohort is concerned. Mean age of around 40 years of age. Mean duration of illness was about 21 and a half years. So they'd had issues with depression for a long time. Many had attempted treatment with antidepressants in the past, and some had actually had psychedelic drug use in the past as well. Average 3.5 previous uses and 9 years since last use. So it had been some time since they had been on psychedelic substances. So the primary outcome here, I have some things outlined here, and we can go look at some of the graphs, but the grid HAM-D scores were significantly lower in the immediate treatment group at 1 and 4 weeks post-treatment compared to corresponding time points. They did analysis of variance scores looking at the significance of time effect, and this is one of the biggest drawbacks of this study. So because they had this waitlist delayed group, they did look at the analysis of variance between the two groups, and then they determined that there was no significant effect of condition between the immediate versus the delayed treatment groups. So they essentially just collapsed all the data across both conditions. So at the end of the day, you just get one graph that shows the difference in treatment. So it's kind of hard. It kind of makes you question why there was even like a waitlist group, because everyone got the same treatment. It was a little bit delayed, but then they just put all the numbers together. And we'll look at those graphs here in a little bit. But the grid HAM-D scores for these patients decreased from initial mean of 22, around 23, down to a pre-treatment baseline of 8.7 at 1 week, 8.9 at 4 weeks, and then this is kind of persistent throughout. It goes up a little bit, 9.3 at 3 months, 7 at 6 months, and then 7.7 at 12 months. So initial starting around 23, dropping down to a mean of about 7.8 on this grid HAM-D scale. So pretty significant decrease in their depression scales. And this is, like I said earlier, blinded clinicians who are discussing their symptoms over the phone and then scoring them. Next thing I have here outlined is 17 out of the 24 participants, they showed, the clinical response rate that they considered significant was a greater than 50% reduction rate, and 71% of participants showed that at week 1 after treatment. So their symptoms were significantly reduced. 58% of these patients 1 week after the initial treatment were considered to be in remission. The final response and remission rates ended up being around 75% response, so greater than 50% reduction, and then 58% of the 27 patients were actually considered to be in remission. And this is their final 12-month follow-up that they got these numbers from. So they looked at, like I said, adverse events previously or throughout the prospective trial. They said that psilocybin did not exacerbate depression in any of these participants, but 3 did not meet criteria for a treatment response. So these patients started with really high grid HAM-D scores and essentially just maintained those high scores throughout. They didn't receive any benefit, but they note later on in the study that there was no significant adverse events noted. There was like one patient who had persistent alterations of perception and some headaches and those kinds of things, but they only really discussed one participant having adverse events, and that they weren't persistent throughout the entire trial. So they didn't even record them in the actual study. This is like in a secondary document I had to open up. So some patients actually started back on their previous antidepressants. This is kind of looks like around the 3 month period. If I'm reading this correctly, 4 weeks. So at 4 weeks, no patients were restarted. At 3 months, about 12.5% of patients had restarted. At 6 months, about 20% of patients had restarted, and then at 12 months, there was about a third of the total patients who had restarted their antidepressant use. Okay. So this is what I'm talking about, how they just compressed all of the data together for both of the trial groups, so there isn't a comparison. But this is kind of their initial 1 week post-treatment, 50% reduction or more in their grid HAM-D scores, and then kind of the persistent lowering in some of the patients that are in remission. The large intervals here are plus and minus 1 standard deviation. These are all the individual participants. So these are some of the patients who started with really high grid HAM-D scores at baseline and just didn't receive any clinical benefit. Some of these other patients kind of initially had some benefit and then persistently through 12 months didn't have a 50% reduction. And then I kind of skipped a lot of the overall well-being score because at the end of the article I read that they didn't correlate well with decrease in depression, which was the primary aim. So I didn't really dig into these too much, but they're all the subjective MEQ 30 questionnaires and their subjective questionnaires that the patients did themselves. They didn't really correlate well with their grid HAM-D blinded assessments. So it didn't seem like those were of much benefit to the overall study. Yeah. And this is what no serious adverse events, suicidal ideation remain low. No instances of self-injurious behavior or reported use of other psilocybin or other psychedelics. And no participant met criteria for the hallucinogen persisting perception disorder, HPPD.
Which is flashbacks, which we know there's a low incidence of flashbacks with psilocybin compared to something like LSD.
Yeah, and my understanding is that's something that you get years out too. So, I mean, a 12-month trial, you may have some of that, but I would imagine that's also something that's several years down the line. But yeah, I think that those are the primary outcomes. I don't know if there's anything. So, I mean, their conclusion was that it seems to be, psilocybin-assisted treatment for major depressive disorder produced a large and stable antidepressant effect through their 12-month treatment. And according to their study, they had no adverse effects. And they used a weight-based dose, but there's a discussion that there's some studies that show. So I think Jeffrey's trial, the max dose was 25. These patients were receiving greater than most of them were receiving at least 25 milligrams of psilocybin or more, and had no adverse events. And potentially this versus a fixed dose, that would be something to look into in the future. But some of the limitations of the study, again, is that they didn't really have a comparison group. They didn't really have a control group. They weren't able to determine drug preparation procedures and how the day procedures may be, in the absence of high dosing psilocybin, may have skewed their study because they had a really comfortable room with a facilitator and they did a lot of, they basically controlled for all that, but in other settings that may affect the results. I don't know if anyone else who read the study had anything that they found that was important that I didn't pull out of it, or
Well, I think it was a complicated study, but it was a follow-up out to a year. And I think maybe the big take-home points were patients who had a response and a remission, the rates were high at 1 year. It was like 75% of response and 58% remission. And it was also 33% ended up needing to take another antidepressant to sustain their response. But I think the sort of the good news part of it is whoever seemed to respond at the 1 to 4 week period of time were likely the ones who were going to respond long term. And the people who weren't, so you don't have to wait a year to figure out if this is going to work. By 4 weeks, if it's not working, you just need to do something else. So if at best I can describe this as a pilot study, extended analysis of a pilot study, because there really only had 24 people in the study. So it was a small group. It was done reasonably well, but without a control, so it wasn't really completely blinded. It was sort of supported by this institute, but as opposed to the other paper where there was a lot of hands-on, who wrote what and who analyzed stuff, the Hefner Institute had more of a funding only with a hands-off and let the Johns Hopkins researchers do their thing under standard sort of publication ethics. So maybe there's a chance that it works in some groups of people, highly screened groups of people who clearly had spent half their lives being depressed. The average age was 40, and the average duration of depression was 20 years, which is, to me, is quite substantial as far as severe depression, as far as the inclusion group. So to have a sustained response rate of 60%, 58% is pretty good for a study for looking at literally a new drug analysis. I'll kick it back to everybody on the group. So what do you think, knowing what we know now, if you were sitting in the FDA, would you approve this drug? Or did you say, let's do some more research and get bigger numbers than 50 patients here, or 59 patients there, and 24 patients here to move forward? Dan?
I'm always interested in getting new and better data. In reviewing these studies as part of putting this manuscript together, I find the research very interesting, and I think that there's some very solid people that are kind of leaders in the field. I do also think that there is a lot of hype and enthusiasm, and when it comes to I get caught up in the distinctions between the clinical research, which is very interesting, and then what's starting to happen here in Oregon, which is definitely not clinical research, but it has all of the appearance of being research. So it has the facilitators, and it has the preparation session, and it has an integration session, but the person on the other end of this is going to be, a person who doesn't necessarily have any kind of clinical training. So that's the part that I just can't get past at this point. So the other thing for me, in terms of what's going to start happening here in Oregon, is just to keep in context the difference in dose scaling. So we're all toxicologists. We think about doses. The doses that have been used in these clinical trials are anywhere between 10 and maybe 25 or 30 milligrams. People who are going to be accessing psilocybin services here in Oregon are going to be able to request a dose up to 50 milligrams, which I think by anybody's standards is basically an incapacitating dose. So it doesn't really answer the question that you have, but I think it's all stuff that we all need to be aware of, because you're probably going to be on the other end of consults when things really start happening here in Oregon.
Yeah, as far as that goes, I did ask to get some data extracted. I don't have Oregon data, but I have national data. So poison centers get about 200 calls per year in the adolescent age group, because we have access to the adolescent database, about psilocybin-related symptoms or some reason for calling the poison center. So that's not a lot nationwide. It'd be interesting we'll try to break out the Oregon-only data and perhaps watch this going forward to see what the numbers are. But I agree. I mean, to me, the biggest disheartening thing about this is whether it works or not remains to be seen. I'm all for doing the research and not making it a Schedule 1, never touch this drug ever again, as if it was, heroin or something like that. Certainly, I don't believe that people who use this even recreationally deserve to go to jail for any reason. But the fact that we just voted, influenced by $5 million worth of advertising, to make this happen rather than think this through as scientists and medical professions, just seems to be a process that should not be repeated. I think the horse is out of the barn, or whatever expression you want to use. It's going to happen. We're going to have to see what happens. I don't think the people who open these centers really want to be studied or have their clientele studied. I would be surprised if there's any sort of systematic way that it is studied as far as who's involved in these cases and the therapies that they're proposing.
Well, there's some legislation that's being heard in the current session that would address the issue of collecting information, because the measure itself didn't have any provisions for collecting information about either safety or efficacy. I mean, I don't know how you define that when you're not technically doing treatment in the first place, but that's something that you might hear about in the near future as people start to debate it. But yeah, I mean, I find it very difficult to find any meaningful way to get relevant data based on the way that this is going to be rolling out here. At least relevant data in the context of safety or efficacy, based on the way that this program is constructed here. And again, it just gets to the whole kind of paradox of this is a program that is by definition not treatment here in Oregon, but it has all the appearance of treatment, and it has people who are seeking it because they want treatment, and so it's just really messy.
Right.
Dan, can I clarify one thing? From my understanding from your article and from the reading in the law, or the rules, I should say, if you, let's just say you were a physician and you wanted to get this certification to give psilocybin to people, you are expressly forbidden from treating them for any medical disorder. So
Right.
all of the stuff that we're talking about today has nothing to do with Oregon. This is recreational psilocybin use, period. You are forbidden from using your advanced degree to treat anyone at all. It is specifically written in the rules that you're not allowed to do that. So, like,
Right.
whether you believe it works for depression or not, immaterial in Oregon.
Right. So yeah, there may be
Getting
doctors. Yeah, there might be nurses, doctors, psychotherapists that want to provide these kinds of services and go through the training to be a facilitator. But yeah, if they do that, the law actually prohibits them. The psilocybin rules prohibit them from using their license privileges in the context of providing these psilocybin sessions. So again, it's just very. I mean, it couldn't be more messy than that. The only other thing I'll say, again, this is not really on topic with regards to treatment and safety and efficacy, but it's more Oregon specific, is that, with all the issues that I think are that we're going to be facing here, one of the real bottom of the road, bottom line issues is the amount of money that it's going to take for a person to become a facilitator. I've learned over looking at these programs is anywhere between $10,000 to $12,000 to become a facilitator, and then $1,000 a year as a license on top of that. And so there's a lot of concern that when these places really open up, the cost of going on one of these trips is going to be, more than a business class airline ticket to fly across the country, and no one's going to pay that. And so the other side of that issue is that it's probable that people are going to go about acquiring psilocybin the way that they've been doing it for decades, which is on the black market. And so you might see more places like the place that got closed down in Northwest, the Shroom House, popping up all over the place. And so again, it's just something to be aware of, because I think that the cost of all of these services may be just bottom line prohibitive for the vast majority of people.
Right. And then, of course, there's the internet, which will continue to edgily sell things like this as well. I think maybe the best hope is the Australians, if they really did this right, limited this to a licensed psychiatrist prescribing it. Perhaps there's a chance that some data will be collected, and a few years from now we'll have some outcome studies that make sense of all of this.
Yeah, Zane, I would say, looping back to your original question, not even remotely close to an FDA application. Like, not even remotely close. The studies so far have been so poorly controlled. Their outcomes are all flawed. They're asking 12-month follow-up, even though we started a third of you on antidepressants. How's your depression? I mean, it's really intriguing. This is early research. This is like the exciting stuff, but there hasn't been a good study yet on this at all.
Right.
And it's not even remotely close. to FDA. I mean, you'd get laughed out of the FDA if you tried to put a package together with this. This is just, someone clearly would have done it already. It's going to be outrageously profitable if it ends up being approved for depression.
And I think people are being snowed.
Got to get better.
All the politicians who put forth for this, they were told all this overwhelming research. Well, there's hundreds of papers that cite the same studies, which are not great studies because we just talked about them all, that just keep getting regurgitated and churned over and over again. There's a lot of stuff out there. There's 500 articles written about this, but really there's only less than 5 articles written about this, and they're not overwhelming.
It's about 100 patients overall.
Yes, there are
really
more
studies.
Like I said, there are more authors than patients
subjective
to date.
Yeah, right. And subjective outcomes in depression, which is like we've been studying depression for decades, and there's good ways to study depression and asking someone, hey, remember when we gave you that? I mean, that's the problem with studies like this. It's all in the stuff you can't read in the methods section. It's all in that. And so you need to have, a study that controls for all of those things. And, the truth is, if there's a placebo effect associated with mushrooms, I don't care. If 20% of people are less depressed and it's all placebo, then fine, take the mushrooms. I don't care. Even if it's all placebo, if it works, it works. But you got to do a better job of controlling for this.
Yeah.
I don't care if the effect of it is placebo. It doesn't make a difference to me. As long as it has an effect, it's great. But we haven't proved that it has an effect yet.
Yeah. Well, we will all keep our ears and eyes open, and we will anticipate call volume to go up, and we'll anticipate ER visits as well to go up. And unfortunately, people going into primary care will see people showing up requesting this from their primary care providers who, as Rob just mentioned, cannot prescribe this. They may direct them to the office down the street that's now being approved to take their money outside of the insurance to provide the service. So anyway, thank you all for presenting. This is an ongoing issue. We'll follow up periodically from time to time. And we'll see everybody next time we do a big journal club. Thank you.
Sounds good. Take care, everyone.
Yeah. Thanks, Dan, for adding.
Yep, good to be here. Bye-bye.
Yeah.